So this is a 60 years old male patient, known case of diabetes, uncontrolled diabetes and hypertension, and smoker. And he presented with the CAD SCS NSTEMI. His drop T was 20,000. But on ECG there was only ST depression. There was no ST elevation. And this is the angio. You can see the ileocaudal view, and you can see how thin and small vessels are. You can see there is a, in OM2 there is a significant stenosis, in LAD there is a significant stenosis. This was the ileocaudal view, and you can see how small the vessels are. This LAD is just like that catheter, which is of almost 1.8 or 2. And this is a apicaudal view, and you can see the LAD proximal lesion, OM2, and this is the collaterals, which is going to probably RCA. This you can see the collaterals is going to the RCA from the septal LAD. So we thought of RCA is the culprit for now. And this is the epicranial view, and you can see the LAD how thin is, and right from the proximal LAD, mid LAD there's a lesion and a small LAD. This was the areocranial view, and this is the RCA. You can see the imprinting of this thrombus in right from the ostium, and you can see the very minimal flow into this RCA. So we called the relatives, and we showed the angio, and we have given the bypass surgery, CABG. But they said they were not willing for the CABG because there was a triple vessel disease, and we thought of doing CABG will be better for this patient, but we had a hope that this RCA has a thrombus, so we can do RCA. That is what one option we have given them, that for time being now we will do the RCA, and we'll try to open the RCA, and then we can do the stage LAD and OM. So they said anyhow they are not going to do a CABG, so then they have given the consent for the angioplasty to RCA right now. And with the right radial route, this is the JR catheter, we went ahead, and in this guide shot there's no flow in the RCA, you can see. So this is the BMW PTCA wire, it easily went, and you can see the flow has come, somehow flow has come. Now it has pretty clear that we has to put stent right from the ostium because there was a lesion and thrombus. And this is the cranial view. To get the idea of stent size, we have done the multiple dilatation with balloon, and then after dilatation it has happened, totally it has gone. Patient's BP went down, bradycardia. Then we took a stent of 2.75 into 24, and anyhow we wanted to deploy the stent as early as possible so that the RCA will receive the blood. And then we deployed the stent right from the ostium, you can see, and this was the scene after the stent deployment. And we wanted to flare right now, so push the balloon down to see the flow. So this is the flaring of the stent we were doing. We kept 1 or 2 struts in the aorta. This is the ileocaudal view, and we are doing the flaring. Actually there's a different balloon for the flaring, but we didn't have that, so we did the flaring with this balloon only. And then this was the scene. So you can see the sort of dissection or thrombus imprintment there just after the stent. We're not pretty sure whether it is a dissection or a thrombus imprint due to pushing of the balloon. So we decided to put a second stent over there. This is the areolateral view, plain areo. The same thing you can see. So probably that is a thrombus which has moved from the that part to the distal, and that is why it is looks like that. So we took a second stent and we placed over there. You can clearly see in this lateral view, RO plane view, the stent was 2.75 into 15, and we deployed the stent at 12 atmospheric pressure. Nominal was 8, and then we overlapped the both stent. So this was the scene after the deployment of stent, and there's a TME3 flow. There is a cranial view. Then the patient got stable, BP came up, and his chest pain got relieved. I was stable, BP stabilized, then heart rate stabilized. So this was the selective angioplasty to RCA, and staged for LAD and OM as per the patient's wish. They did not want the CABG. This was the angioplasty to RCA in this NSTEMI patient.